Hi, good morning. It's always so great to be at this conference. I appreciate all of you coming out today. I'd like to say how much I appreciate the efforts of the Glaucoma Service Foundation and the Harley Foundation and Rita Stern in making this event everything that it is. So I'm going to talk a little bit about surgery, and of course I'm only going to cover some of the high points, and I don't have time to be comprehensive. So the new discussion in the last few years in glaucoma surgery circles is about MIGS, or minimally invasive glaucoma surgery. So the definition, as I like to joke about minimally invasive surgery, is minimally invasive surgery is surgery you do on someone else. Invasive surgery is when it's done on you. So I think whenever there's a sharp stick and an incision involved, we shouldn't fool ourselves. It's still surgery. So although I'm going to be talking about surgeries that may have less risk, there's always risk to surgery. Now, I'm a surgeon. I'm not against surgery, but we just have to balance risk and reward. But these surgeries I'm going to talk about do have less risk. They tend to involve less cutting of tissue, which is a good thing. And usually it's a quicker surgery and a quicker recovery for the patient with less post-op visits. Usually, but not always. So Dr. Lee was kind enough to lay the groundwork talking about the anatomy of the eye. So here's an eye cut in half, and as he said, fluid is made back here, and the back part of the eye comes through the pupil and drains in the drainage channel between the iris and the cornea that goes around the circumference of the iris, the colored part of the eye. And if we cone in on this area here where the iris, here's the pupil, the lens, the iris meets the wall of the eye, there's that trabecular meshwork and then Schlemm's canal and the outflow channels he talked about where a lot of the fluid drains, and this other area here. So I'm going to talk about different ways that surgeries in this group affect outflow of fluid. Because, of course, in glaucoma, we are just the world's smallest plumbers. Glaucoma is a plumbing job. Pressure in the eye damages the optic nerve. The problem is that the fluid outflow in the eye isn't sufficient and the pressure builds up. And so all of our treatments are trying to increase outflow either by clearing the drain or by making a new drain. I'm going to briefly talk about all these new surgeries. What an exciting time to be a glaucoma surgeon. We have so many new treatments now, more new treatments now than any other time in the history of glaucoma. I'm going to start with talking about the eye stent, which is FDA approved and has been out now for several years. And that was the first FDA approved of these MIGS devices. So in that drainage channel here, often a problem in glaucoma is blockage in the trabecular meshwork, this first approach to the drainage channel. And so the eye stent, this very small titanium snorkel, about 1 millimeter long, bypasses across the trabecular meshwork here to allow fluid to more easily get drained from the eye. And this shows you an artist's rendition of a small 2 millimeter incision. This stick is an inserter, and the eye stent is placed like an IV into this 300 micron, that's a third of a millimeter channel called Schlemm's canal. And there you see the tip of the eye stent sticking out in a patient of mine with a brown iris, and this is the trabecular meshwork here. So you can see it's a very small surgery that often lowers pressure well. Now in America, it's approved when done in combination with cataract surgery. In other parts of the world, the eye stent is done as a solo procedure, but here in America, it's just approved for in combination with cataract surgery. And in the original trial in America, to show how well it worked, they compared cataract surgery alone to cataract surgery plus eye stent. And trying to achieve a pressure of less than 21 on no meds, the eye stent improved the success rate from 50% in cataract surgery alone up to 72%. So you are about 20% more likely to have good pressure control without medications. A secondary outcome measure was trying to get a pressure reduction of at least 20% from baseline at a year on no medications. And again, it was a little less than a 20% greater chance. So compared to cataract surgery alone, this procedure increased the rate of pressure control without medications. Now, the other interesting thing about this study was just how safe the eye stent proved to be in this study of a few hundred eyes. You can see low rates of complications, and these were not severe complications, and indeed no patient in this study lost vision because of the insertion of the eye stent. That's not to say there isn't risk, but just there's clearly less risk than traditional surgeries like a trabeculectomy or a tube shunt. The head of the Wills Glaucoma Service, Dr. Katz, and other people on the Glaucoma Service published a summary of articles, different articles showing the effectiveness of the iStent for controlling glaucoma, including this study where they put in 2 of the newer models of the iStent without cataract surgery. This was done elsewhere. And you can see that the pressure reduction in the group that had the iStent, the dark bars, was much greater than patients who just were placed on 2 medications. So relatively safe surgery, relatively good results, but the pressure reduction isn't as much as some of the traditional surgeries. So it doesn't tend to get the pressure down to 10 or 12, it gets pressures closer to 15. And I mention that because this surgery is not for everyone. Why? Some people need lower pressures. And in America, if you're not having cataract surgery at the same time, then insurance and Medicare will not pay for your iStent surgery. Now, the Hydrus implant, shown here on the right, is like an iStent that's grown much longer. Instead of just being 1 millimeter long, it's about 6 millimeters long. And you see that this is that same sort of picture of the inside of the eye, and here's the tip that lets fluid get more easily into Schlemm's canal. But instead of just that 1 millimeter, we have a long implant that helps to open up Schlemm's canal wider. And this is injected, much like an iStent, into the drainage channel from inside the eye. It's made out of a very special nitinol alloy, which is a very flexible metal. The Hydrus implant was compared in one study to SLT, which many of you may recall from Dr. Pro's lecture is the laser to help lower pressure in open-angle glaucoma. The SLT, of course, is done in the office, whereas the Hydrus is done in the operating room. And in this study, they both lowered pressure about the same amount. However, the difference was that the patients who had the Hydrus required much less medication after the procedure than the patients who had the SLT. So the average SLT patient still required 2 different medications, whereas the average Hydrus patient required less than 1 medication. So the Hydrus probably is more effective than SLT, and in this study was fairly safe. Now, I've been talking about ways to bypass the trabecular meshwork. Well, there are also some procedures that are designed to try to open up the drainage channel and sort of flush the drainage channel by injecting viscoelastic, which is sort of thick material like jelly that dissolves in the eye. So you can inject this jelly into Schlemm's canal to help enlarge it and maybe help flush it. And this device here, you can see this little tip is a cannula that can be placed into Schlemm's canal, and then you inject fluid. And there are a number of ways, like the Visco 360 shown here, or ABIC, which stands for ab interno canaloplasty, the canal, so canaloplasty means enlarging it. There are relatively few studies that show yet how well these techniques work, but they're underway now. In fact, one of the studies is underway at Wills Eye Hospital Glaucoma Service comparing Visco 360 to the laser trabeculoplasty, the SLT, much like in the last study I just told you about of SLT versus Hydrus. So if you're interested in helping to drive forward knowledge, science, and the care of glaucoma, my friend Cheryl Wizoff in the lobby would love to talk to you about some of our studies, such as the Visco 360 study. Now, rather than placing implants across the trabecular meshwork, another approach is to just open up the trabecular meshwork surgically, to just cut it open. And this device, called the Trabectome, has a ski plate, an electrode for electrocautery to cut open the trabecular meshwork to Schlemm's canal. This shows you a similar view again of a surgeon reaching across with this instrument, and that surgeon is going to cut open almost 180 degrees of trabecular meshwork into Schlemm's canal. Now, the trabectome is a relatively simple, straightforward procedure for the surgeon and usually a fairly quick recovery for the patient. However, in a study by Dr. Rhee, who used to be here on service at Wills Eye Hospital and is now in the Midwest, he showed that patients who had the trabectome, and that's shown in this line here, this is the success rate. So at 3 months, everyone was successful. But by 2.5 years, only 20% of the eyes were still successfully controlled. So 20% success rate isn't very exciting as a surgeon. I'm sure it's not very exciting from a patient's perspective. And that's part of the reason why the trabectome is not that commonly performed, although in certain patients it has a better prognosis. So there are a number of approaches that are under investigation and are being used that are like the trabectome. They open up the trabecular meshwork into Schlemm's canal, but use different instrumentation that is simpler and hopefully allows for a more lasting result. Some of the members on the glaucoma service are performing GAT, or gonioscopy-assisted transluminal trabeculotomy. That's GAT. A similar approach is the Cahook dual blade, which is a clever instrument with two blades to cut out a strip of trabecular meshwork. And then the Trab 360 shown here, where this stiff plastic suture is injected into Schlemm's canal, and once it's in there, by withdrawing the suture, one tears open Schlemm's canal. Tearing isn't a good word when you're talking about surgery. Maybe I should say one gently opens Schlemm's canal. So all of these procedures can be effective in the right patient, but they don't lower pressure as much, and in some patients there may be a little greater risk of bleeding. So again, part of the art of medicine is to match the patient with the treatment, and this is not for everyone, but for some patients very effective. The suprachoroidal shunts, CyPass and Supra, the CyPass was approved by the FDA earlier this year, at the end of last year, and is just now starting to be implanted. That's made by Alcon. This shows you a larger tube, although still small in the big scheme of life, that's been placed between the iris and the wall of the eye. And so where this is placed is, as the green arrow shows, inside the sclera, but just above the ciliary body. So that space, which normally is closed, is able to absorb fluid very readily if one can get fluid to it. It's called the suprachoroidal space. And so this implant, shown here to give you a scale of 6 millimeters long, can be placed into the suprachoroidal space, again, from the anterior chamber, a small incision, but less than 2 millimeters, and diverts fluid. And Steve Vold in the Midwest performed the COMPASS trial comparing the CyPass in combination with cataract surgery to cataract surgery alone. And essentially I'm showing you with this graph that the pressure reduction, so in this graph lower is more, was almost 8 millimeters of pressure reduction with the CyPass versus 6 with phaco alone. And when we got out to 2 years, that's a 7.5 versus 5.5. So the CyPass clearly lowers pressure more than having cataract surgery alone, but like the iStent in America is only approved when done in combination with cataract surgery. That has to do with how it was submitted to the FDA in America. One nice thing about the CyPass, like the other surgeries I'm talking about, is it has fewer complications and less serious complications than most of the traditional surgeries like trabeculectomy or tube shunt. But it may not lower pressure as low or as long as trabeculectomy and tube shunt, depending on the patient. And again, if you're not having cataract surgery, it won't be covered by insurance. Very similar to the CyPass, if you're not a patent attorney, you might think that the Supra made by Glaukos looks a lot like a CyPass. And indeed, it's injected into the same part of the eye in a procedure that seems a lot the same. So I expect there will be some patent disputes about that. But this is a slightly different material, and Dr. Katz and I have had the opportunity to inject these things in Armenia, where some of the trials were underway. And again, a relatively straightforward procedure that's much shorter with a quicker recovery than traditional glaucoma surgeries. This is a study we were part of that looked at this Supra, again, this suprachoroidal shunt, done without cataract surgery, just the Supra alone. And in this study, patients started on 2 medications with a pressure of 20. They were then washed off their medications. Their pressure went up to 24. And they were then underwent Supra implantation and were continued just on 1 medication. You can see that the pressure of about 20 with and 24 without dropped down to 13 with that 1 medication. At a year, we washed them out from the 1 medication, and the pressure went up to 16. Still a very good pressure reduction. They were placed back on the medication again, pressures of 13, and then 17 at 2 years when they were washed out again. This just shows you that even without cataract surgery, these MIGS types of procedures can be very effective, although they're not yet approved in the U.S. in that fashion. Again, relatively low complications. So I've talked about bypassing the meshwork, opening the meshwork, bypassing to the suprachoroidal space. Our traditional glaucoma surgery sends the fluid out of the eye through the sclera to the area under the conjunctiva. So Zen is a new approach, this tiny, tiny tube here, very small tube, that can be injected across the sclera to divert fluid under the conjunctiva. So that's almost the same as what a trabeculectomy does. The difference is this can be done through a 2-millimeter incision in a shorter surgery with a quicker recovery. And because this is a very long, very, very thin tube, it helps limit how quickly the fluid gets out of the eye, which helps to protect against the pressure dropping too much. And in one study of this procedure, patients who started with a pressure of about 22 on average wound up with pressures about 15 on average, followed out for several years. Again, compared to traditional surgery, glaucoma surgery, the Zen procedure has a much lower rate of bleeding, so far no infections, and less likely to suffer problems of the pressure being too low. Unlike the other surgeries I talked about, this surgery is approved to be done without cataract surgery. So patients who have glaucoma but don't need cataract surgery are candidates for this procedure. However, because it was only approved by the FDA recently, a lot of insurers are still not covering this procedure. A very similar procedure is the InnFocus MicroShunt. It also has a long, thin tube, although the tube is a little larger, that bypasses fluid from the anterior chamber to the subconjunctival space. It is not yet approved by the FDA, but probably will be within the next year. And the main difference is, unlike the Zen, which is injected from the inside of the eye out through a very small incision, in this procedure one needs to make an incision on the outside of the eye and you inject it from the outside in. So a little bit more surgical dissection, which may make the eyes a little bit more irritable the first couple days, but the results for this procedure so far have been truly excellent, with pressures winding up down to the 11 and 12 range, even out to 1 and 2 years. So this is an exciting time to be a glaucoma surgeon. There are a lot of new procedures. All of them seem to have some potential advantages in terms of safety and quicker recovery. Some of them don't lower pressure quite as well, but not every patient needs a pressure that's super low. So we'll see which of these are still here in 5 and 10 years and have proved their worth, but it's nice to have new things to report to you. Thanks very much, and thanks for being here today.
Any questions?